Hello, it's Phil again here at Healthcare Business News, and today I'm joined by Sean Connolly, who is the Imaging Services Manager at the University of Maryland Medical System, which is a very important job, and I appreciate, Sean, you taking time away from your busy schedule to speak with us. Thank you for joining us.
My pleasure.
So, Sean, we interviewed Sean, and he contributed to our January, February issue of Healthcare Business News, talking about the alternative equipment maintenance program. So, just as a starting point, Sean, describe to us what is alternative equipment maintenance.
So alternative equipment maintenance would be anything that you do out of the recommendations of the manufacturer. So a good example is with the thermometer, we'll use something very simple. If the manufacturer recommends an annual preventive maintenance on that device, and you determine from your experience with it that you don't need to do PMs and run to fail, that would be considered an alternative maintenance approach.
I see. Uh, is this across the board from imaging equipment and linear accelerators all the way down to thermometers, or does it apply everywhere or just some places?
Well, imaging equipment would not be included in that. It's actually excluded specifically from an alternative equipment maintenance schedule. Critical items, and that is often identified locally as what you consider a critical item, they are also excluded from an alternative equipment maintenance approach. So no, it would not be all inclusive. It is more of the devices that fit in with that group of devices.
So I think it's fair to say that AEM is still in its infancy. What role does artificial intelligence play in that program?
Well, that would be the predictive modeling. So if you can gather information either from the device directly or through your database to determine mean time failure between, breakdowns, are you replacing parts when you're doing PMs, anything that can give you substance to support your alternative equipment maintenance program. Um, if you can prove that this device uh, operates no differently when you don't do a PM for 3 years, and you're essentially doing a verification that the device is working accurately, but there's no need to replace parts or adjust any um, parameters on it, then it would help you predict when an alternative equipment maintenance approach is acceptable.
I see. Um, Now, what about the pandemic? How has the pandemic influenced AEM and your site specifically? Pardon.
Well, I really don't think the pandemic really has influenced the AEM. AEM has been an ongoing discussion within the career field for many years now. When they first offered the AEM as an acceptable approach to maintenance, I think a lot of people probably misused the program. And what I mean by that is they were changing PM schedules from annually to maybe every 2 or 3 years. They were completely removing PMs and putting devices on a run to fail approach. And this was without the needed support to say that that was a viable approach to maintenance on that program. Now, with the pandemic, it really hasn't affected PMs. It's more affected our operations, our day to day, what we do, how we do it. Our team's been greatly affected by the pandemic because we are a system clinical engineering program. So we have been on the forefront of collecting a lot of equipment and supplies to be redistributed to amongst our facilities.
Um, what about you personally? How are you dealing with the coronavirus?
Well, me and my team, since we are in radiology and we we did reach out to the state to see if we could put off our PMs and things of that nature. We really did not get approval. The state of Maryland requires you to report to the state all of your PMs on any radiology equipment. So my team has been going along as normal. I know a lot of non-essential personnel within our system have taken to work from home. Me and my counterpart, he's our database administrator, we're here pretty much every day receiving supplies and equipment. I actually work out of a corporate office, but we've turned one of our floors into a receiving area for surge equipment and consumables and things of that nature. And we've also, since we are a system clinical engineering program, we've also been involved in distributing that equipment and those supplies on an as-needed basis.
Do you believe that alternative equipment maintenance, is there any data that would suggest that you're saving the hospital? Logically, I assume that you're saving the health system money, but is there any data that supports that?
There is data that you can use, and that would be, let's take for an example, not that I would ever recommend putting an infusion pump on an AEM, but let's just say you have 1,000 infusion pumps in your facility, and it takes 30 minutes per annum to do that. That's 500 hours and pretty much a quarter FTE per year if you're taking a run-to-fail approach on such a device. So that's where the monetary value comes out of it. That's really the biggest return on investment is technician time when you shift to an AEM program.
And when you shift to an AEM, you dispense with some perfunctory or non-essential maintenance routines. Is that correct?
Yes, sir, that's correct. And a lot of the vendors out there are actually incorporating it into their programs. Your CMMSs, two of the larger CMMSs, computerized medical maintenance systems,
right?
They are actually including that as part of their programming. So not only can you get data from your local program on the equipment that you may be considering for an AEM, but also nationwide standards. So the data is starting to be collected from more of a global perspective to see when an AEM is the appropriate approach for certain equipment.
Can you modify the CMMS software to allow you to extend the maintenance schedule or change?
Absolutely. That is done locally. You determine that. The Joint Commission, what they hold you to is the standards that you set for yourself. So you establish your MEMP and you pretty much indicate in there how you will perform your PMs. For a while, they came down and the FDA had said no AEMs, and then we went back to, okay, AEMs are acceptable with the appropriate documentation. So it's been a discussion for quite a while, and it's still going on. And I do think people have to be cautious with the AEMs. You don't want to do it to reduce staff responsibilities or needs of staff. You want to do it when it's appropriate, when you know the equipment does not necessarily need to be looked at, on an annual basis or things of that nature.
Well, this is a sort of practical modification, a practical approach that's required in today's healthcare community, and we're lucky, those of us, we're lucky to have people like you working on this sort of thing. So thank you very much for that.
Yeah, my pleasure.
And thank you for joining us today. I very much appreciate it, and I'm honored to have you here.